So great to see you all virtually. So appreciate you having me give the talk. And Bob actually has heard all this stuff before because he was part of an ICL that we put together at IMAS that we just got back from, talking about cervical deformity and thinking about where are we now. And so want to thank Virginie Lafage. I stole some of her slides because I really think this is where the crux of it is understanding what is cervical deformity, what is the alignment that we need to worry about, particularly for you more younger in training folks need to be. So I have a hard time thinking about the stuff in absolution. So I have I've got a case to go through. So this is my case, 53-year-old female, neck pain, can't walk. And on exam, she's hyperreflexic with positive Hoffman's. She's got full motor strength, but and has a very low MJOA score. And so when we hear all that we think myelopathy and cervical disease. And here are her images. You can see here's her neutral X-ray, and you can see a significant amount of kyphosis. She has a little bit of a coronal abnormality, and then significant disease in both flexion extension, with really not a ton of motion in flexion extension, even though she promises that she's working hard. And if we get advanced imaging, you can see the spinal cord kind of heading off here, heading over to Encinitas, and then heading down here through. This was the rougher patch of San Diego, and you can see mass amounts of compression on multiple levels with the that can explain the myelopathic findings she has, and then also just a tremendous amount of disease in terms of disc level, listhesis at 7-1, multiple different locations. And so the question is what do we do about this? And so humans have evolved from this quadrupedal mobility and motion to now this bipedal motion. And with that, we have changed our alignment in terms of what things look like. And this has happened over 7 million years. And that change really has been has been lots of stuff, but in addition, it has also changed the amount of shape that we see and the kind of shape that we see in the thoracic and lumbar and then cervical spine. And really, lordotic lumbar spine is really a human feature, and it's done to improve and allow for that locomotion to occur and allow people to put their heads where they need them to be. It's not just the lumbar spine, it's also the cervical spine. And so cervical lordosis is also something that has occurred through anthropologic studies. And this is a study just showing the increase in lordosis we see as we get to more advanced human beings. Cervical lordosis is not a new concept, and so it was characterized in the 1960s. And this was kind of one of the first papers that looked at the lordotic curve of the cervical spine, describing how that was the normal phenotype and normal position that we're supposed to have. And since then, there's been multiple reports that look at that and talked about lordotic curvature and clearly described kyphosis as the most prevalent spinal deformity and spinal evil pathology that we need to pay attention to. Loss of lordosis can be associated with increased alignment of the head versus spine, and that creates a vicious cycle of abnormal forces and progression deformity. And this is really written, Spivak in Textbook of Spinal Surgery, and Bridwell's seminal textbook really talked about this pathologic anatomy. There's been several other papers that look that with kyphosis, we see more pronounced kyphosis. We have cord compression, and we have several exam findings, right? Laramie sign and the Sperling's test, where we utilize these known areas of compression, and then go ahead and flex the spine in that position to see if we can get additional compression. And we know that neural compression increases in extension independently of the type of kyphotic alignment, and again, that's how we utilize those signs. Based on this evidence, well, then cervical kyphosis is clearly a deformity. But I guess the question that Virginie had and I have is, is it that simple? What is the natural shape of the cervical spine in an asymptomatic population? And so we know that the cervical spine is critical for cervical spine assessment. It allows the posture to place the head in a functional head position. And really, the goal is a horizontal gaze, to be able to look around the world. Presumably back in the older days, that was to protect us and make sure we could see our enemies coming. Is probably still true today. And then thoracolumbar alignment is all the other stuff underneath it that helps put that head or start that head in the right position. Cervical lordosis, when we look at how things correlate with one another, we know that PI is correlated to lumbar lordosis. We know lumbar lordosis is correlated to thoracic kyphosis, and thoracic kyphosis is correlated to cervical lordosis. If we put that all together, then cervical lordosis should probably correlate to the pelvic incidence, right? But it's not quite that simple, unfortunately. So there's no direct correlations with PI and LL, and it may be that it's just so far removed, and that the thoracic kyphosis and thoracic alignment is so variable. We do know that there's reciprocity between the cervical lordosis and the thoracic spine, however, and the T1 slope is critical towards setting the stage for what the rest of the cervical spine should look like. It's kind of the PI of the pelvis. So the PI of the pelvis tells the lumbar lordosis what to do, and so the T1 slope or the thoracic spine tells the cervical spine. And you can see if it's relatively flat, then the cervical spine will be relatively flat. If it's increasingly kyphotic or significantly kyphotic, then the only way for the cervical spine to be aligned properly is to have this significant amount of lordosis. And so that's kind of and we've seen that in these asymptomatic volunteers. Here's just some examples. And so you can see relatively flat cervical spine. And as we increase the T1 slope, then we increase the cervical lordosis, sometimes pathologically so. The secondary input is horizontal gaze. And so we need to be able to look upright so the chin-brow vertical axis and surrogates like McGregor's line or slope of sight help tell us where the head wants to be. And the cervical spine's job is to get the head in the right place. And we want it to be within this kind of neutral area, about 5 degrees up and about 18 degrees down. And in that sweet spot is really the right place. And you do notice that it's more down than up. And so there's limited amount of cervical extension we need to have. And quite frankly, it's less important as well, because we need to really look down to see where our feet are so that we can walk and walk without tripping. That's the critical aspect of line of sight. And so how much cervical lordosis do we need to maintain that horizontal gaze? And so this is something that Virginie did with the ISSG, looking at 2 databases, EOS asymptomatic images and the ISSG images with horizontal gaze to figure out how much they needed. And it turns out that T1 slope average was about 17 degrees. And so if the T1 slope was less than 17, then actually the amount of lordosis in the cervical spine is not some lordosis, but actually was slightly kyphotic. And that held things in the right place. That was a little surprising to us. And so you can see this is what happens with increasing slope. So high slope, you get significant lumbar lordosis. But then as we decrease the slope here, it's 40. You can see this is maybe what we describe as normal cervical lordosis. But if we get T1 slope less than 17, then actually the cervical spine ended up kyphotic. And here's at -8 degrees of kyphosis. And so 17 degrees ends up being kind of that neutral inflection point where it changes from lordosis to kyphosis. What about alignment? And so now we look at the asymptomatic individuals. And what about normal cervical lordosis effect on age? Do things change as we get older? And so we do know that there's a structural changes, right? We get loss of lumbar lordosis, increasing thoracic kyphosis with time. And then in consequence, we increase our plumb line and increase our T1 slope. And as we've seen, and then the compensatory mechanism, retroversion, knee flexion, ankle flexion, and then cervical lordosis also increases over time to then increase to improve the direct line of sight. And really, but that's mostly driven not necessarily by age, but by this thoracic kyphosis increase. And again, so those two things kind of go hand in hand. And again, here's a patient over time. So at 15, relatively kyphotic. At 40, then it straightens, and then at 60, it increases. But really, it's increasing because that T1 slope is increasing. And so the question then becomes: should we really restore the cervical lordosis below C2, or do we want to keep that reserve of extension in the cervical spine and allowing it to maintain that flexibility and change over time? If we look here, this is a morphologic study of lower cervical curvature looking at asymptomatic subjects. And you can, when they looked at the distribution, they found that around 30% had lordosis that was greater than 10 degrees, so had a normal lordotic curve. But here's what they also found. They found that 40% actually had less than 10 degrees of lordosis. Some had pure kyphosis or sigmoid kyphosis. Some had a relatively straight spine. And so really only 30% in this asymptomatic volunteer group had a lordotic alignment greater than 10 degrees. Here's another one. This was done by Dr. Lueck, looking at the sagittal parameters involved in the cervical spine using EOS imaging. And he found that 34% of patients presented with frank kyphosis of the cervical spine. Again, C7 lordosis. This is asymptomatic volunteers in the Ames ISG classification. And they found that in this group of patients with cervical lordosis grade 1 or grade 2, which was in mean cervical lordosis 0 was actually straight, that they had a significant portion that were also non-lordotic. And so maybe cervical kyphosis is present in 30% of asymptomatic normal subjects. So just looking at cervical kyphosis to define as someone with a cervical deformity is probably not enough. So what is it? What is cervical deformity and how do we define it? Well, we know it's a real problem. So Justin Smith looked at this and found that deformity is the same EQ5D or same disability as emphysema, renal failure. It's worse than blindness and acute MI. And so we know it's a significant problem, but we do need to define it a little bit. What if we just look at x-rays? We can look at x-rays and try to get a sense about whether or not these things look like deformity. Well, these two, probably not, because we've shown already that a little bit of kyphosis probably isn't pathologic. Those might be, particularly if they're associated with some disease. And these ones definitely, right? Significant focal kyphosis. Those are the ones we need to worry about. But but the combination of parameters rather than a single threshold is probably the best way to define it. And so that's really what we sought to do. Now, if we look at cervical spines in absolution, they can be quite misleading. And so here we go, patient with cervical deformity, right? Or is it? And so we can see that it's got a high C2, C7 SVA. It's got some lordosis, that's good. It has some hyperextension that we see in this upper cervical segment, which we think is pathologic. But where does the problem come from? And so you have to look at the whole patient and the whole image to really understand it. And if you look here, we say, well, wait a second, the problem isn't coming from the cervical spine, but maybe the problem is coming from this PJK and the low lumbar lordosis. And so the drivers of this deformity are this kyphosis, there's PJK, there's also some this C2, C7 plumb line difference. And is that a driver or is that just a consequence of the problem? And the global alignment is 13 centimeters off with significant compensation that we see on this X-ray, including pelvic retroversion. So first we need to do with any of these films is remove the compensation. So we relax the pelvic retroversion and allow that to fall forward. And you can see it even gets worse. And so now we see that the C2, C7 plumb line increases by a centimeter. The global SVA increases by 7 centimeters. And so the question now is, well, what do we need to fix? How do we get the patient to stand upright? Is it really cervical disease or is the disease someplace else? And so if we correct that lumbar lordosis and correct that PJK, that actually allows the cervical spine to relax and hold in a better position. And that resets that TL junction, decreases the C2, C7 SVA, restores the horizontal gaze. And this is really what allows us to fix that problem. So cervical disease or cervical malalignment isn't always cervical malalignment. It may be, again, driven, particularly when it's fixed like this, by the rest of the deformity. So don't forget those long films and look at it carefully. When we look at these cervical curvatures, we can measure the C2, C7 plumb line. We can look at focal alignment or segmental kyphosis. We can look at relative motion or extensive motion. And then we can look at where things are in this horizontal gaze. And so when we looked at all this, we struggled with understanding, well, if C2, C7 plumb line alone isn't enough and lordosis isn't enough, what helps us understand what is enough to define something as a cervical deformity? And so we grabbed 12 deformity surgeons and we said, listen, just tell us which one is severe or mild deformity. And then let's look at all the severe deformities and try to figure out what it is that all surgeons kind of agree on, kind of looking at this, um, uh, uh, um, looking at group logic to see if that's smarter than individual parameters. And then we wanted to look at that and say, well, once we've done that, let's see if we can group our deformities into different clusters and start thinking about them and seeing what matters for them. So what we did first is we asked people to look at it, we defined them all, we separated them into a couple groups, and then we looked at what mattered for those patients to define them as a severe deformity. And these are the parameters that mattered. So the cervical SVA, so how high that was, the T1 slope mattered, and then really these dynamic factors or the dynamic extension x-rays, and which really determines whether or not the cervical deformity was fixed. And if it was fixed in kyphosis and couldn't relax or improve, and that really made us worry more about it being a cervical deformity. And so if we look at this, we classified about 87% of the cases were correctly classified with those parameters. And then we could start putting these people in different categories. We could look at focal deformity, maybe this kind of flat neck deformity, and then deformity that really originated from the cervical-thoracic region and then drove the cervical spine into malalignment. And so Hanjo Kim kind of led this effort, looking at cervical deformity and cervical parameters, and did a two-step cluster analysis to look at cervical deformity patterns, and kind of came up with these three different patterns that helped us put things into buckets. And so group one was a flat neck, group two was a focal deformity, and group three was cervical-thoracic deformity. And with these as well, by putting them into these groups, it also helped drive and maybe thought about how we would think about fixing them. And so the flat neck deformities tended to be front back operations because they were stuck but relatively flexible. And so you could think about sometimes posterior only approaches, but usually front backs. Focal kyphosis could either be anterior or in anterior posterior groups. And then cervical thoracic tended to be long posterior constructs, usually with osteotomy to correct that junctional disease. So let's just go through those groups just again. So focal deformity is this focal kyphosis that we see. And radiographically, what that looks like is it looks like a significant kyphosis and it's stiff. And so in the kyphosis and extension, that we don't see any change in its overall alignment. T1 slope is relatively neutral, so it's not a cervical thoracic problem. It's really a problem that's isolated to cervical spine. And then in neutral, it's relatively kyphotic. And the CVA neutral, so the overall alignment of the whole spine is also relatively normal. And this is what it looks like. So kyphosis that's in one area, relatively stiff, so it doesn't change too much in the flexion extension film, but the T1 slope is neutral. So the problem looks isolated to the cervical spine, and the overall alignment is normal. Cervical thoracic deformity, and so these are these higher grade deformities, and the radiographic characteristics of this are the T1 slope is neutral, but it's very high. And then because of that high slope, you have to have a significant large cervical lordosis, and that cervical lordosis is maxed out. And so when you go into extension, it can't extend anymore because it's stuck in that position. The CVA is neutral, but it's very, very high and malaligned. And again, then the C2, C0 area in the upper cervical side is also maxed out in this hyperextension area. And so here's what that looks like. And these are typically PJKs or DJKs. So very high T1 slope. You can see that here, high T1 slope, significant cervical lordosis, and that O1 area is really boxed in. So again, high slope, significant C2, C7 plumb line difference, significant lumbar lordosis, and that hyperextension from C0 to C2. And then the last one is this kind of mid-group, the flat neck. And so the T1 slope is relatively neutral. The CVA is very high, so they're significantly malaligned. The cob, again, is straight or a little bit kyphotic. And then the interesting thing about this one is that these ones are abnormal because they're very, very flexible. And so when you lay them down or extend them, then their extension is substantial and can give you spontaneous correction. And so this is a classic flat neck deformity, again, significant kyphosis. But look at the change in alignment and how substantial it is and that extension view. It's not maybe normal in extension, but it certainly comes a lot closer to normal. And so high SVA, high cervical lordosis, but you can see that dramatic improvement on that extension X-ray. And so we now can define things by a variety of factors, by that flat neck, that focal deformity, or that cervico-thoracic disease, which is really probably more a PJK problem or a DJK problem than anything else. We also know the alignment is key. So, and Bob and I have been talking about this for years. This is a study we looked at with extension. We found the extension view we looked at the final post-op lateral, and it turns out that the extension X-rays really told us what kind of surgical procedure we were going to do, and also predicted the final post-operative alignment at 3 months as well. So that flexibility is critical towards thinking about a surgical plan. Well, what's next? What else do we need to do find out about cervical deformity? And we know that CVBA and the T1 alignment, that's critical. We know that focal kyphosis is also critical, and we can look at simple COBs to figure that out. We know regional alignment, particularly the T1 slope, is critical to understand. And the dynamic aspects and the reserve of extension is also critical to understand. But I think there's lots of other stuff that we still we can't figure out. We've seen that the cervical literature has been ripe with looking at other things, including CPA or CTPA, whether or not it's instrumentation related, what happens to that proximal cervical spine and that reserve of extension. All these surrogates from the McGregor line and CT slopes, and then other innovative ones looking at thoracic inlet and cranial incidence that we don't really know how to include into the parameters we currently have. And all of these are probably relevant and provide some advantages and maybe some incremental information that will be placed into a cervical deformity system in the future. But I don't think we quite understand them well enough to do that now. And so cervical deformity requires a systematic approach. So you need to think about, you need to kind of break it down into its subcomponent steps. And so first you should look at the spine and look at it without numbers. What does it look like? And you can see this is clearly looks like an abnormal spine. And then break it down to why is it abnormal? So where does the deformity occur? Is it rigid? And how do we think about fixing it? And then look at the compensatory mechanisms. So, and how do we relax those compensatory mechanisms? Or if they're stiff, how do we fix them? And then we need to look at the global alignment and think about how we can get things then lined up in the right position, finally, to get our patient standing upright in the safest way possible. There's also lots of misunderstanding or non-understanding of the bones, joints, and morphology. And so we know the facet orientation varies with children. We know there's a certain amount of muscle mass and fatty infiltration and sarcopenia that occurs that might also play a huge role in cervical deformity and myopathies that occur in these complex patients. And so current questionnaires are also not adequate to capture what's happening with our patients. We have these surrogates for NDI and MJOA, but we still don't know what affects our patients the most. And so we need a questionnaire specifically for cervical deformity patients. And so there is some work looking to construct this questionnaire looking previously described methods for HOQL development. And so finally, in my 20 seconds that I've got left, I'm sorry I talked so long, is, what do we do for this patient that has this deformity? And we can think about operative, non-operative, where we stop, and osteotomy. And so hopefully when we look at this, the kind of my thoughts are, first, we look at where the cervical compression is. So the number one thing we need to fix for this patient is her myelopathy. So we need to decompress the spinal cord. And how do we do that safely and effectively? And then the second job, number two, is if we're going to make that stiff by decompressing it, then how do we get her lined up in the right way and do it safely? I think the cluster analysis has some value. And so I'd call this a cluster 2. So this is a focal deformity with focal kyphosis that's rigid. It doesn't fix itself in extension. If it can't get back to fairly close to the right position in extension, then I know I need to do some sort of a release. And if the problem is in the focal cervical spine, then that's going to be an anterior posterior approach for me. If the problem is lower down, then maybe we can do just a posterior only based osteotomy. But those are risky. And so you do want to be careful and cautious about who you do those for, and making sure that those are for the right patients. So here's what I did. I did a corpectomy of that abnormal vertebral body with a cord compression, and then did a posterior-based approach to get things realigned into a better position, allow her to maintain her cervical gaze. Here's what she looks like a year later. And so in resolution of most of her neck pain, she did have some postoperative dysphagia. Again, we do change things substantially with the alignment of the cervical spine, but her MJOA and her hands, most importantly, returned back to essentially normal. So in conclusion, cervical spine is a unique part of spine. It can't be investigated as a standalone segment because it does compensate substantially. There's a lot of variability, and just because you have kyphosis does not mean you have a cervical deformity. That complexity increases with the presence of deformity. And so you do have a reserve of extension. You've got some focal deformity, the pattern of deformity. And treatment includes defining the cluster and then also really figuring out where the spinal cord is compressed so you can decompress it. And just because you have cervical kyphosis does not mean you have cervical deformity, right? So maybe we should be calling it a cervical curvature instead to identify what that looks like over time. All right, that's it.
Awesome, Eric. Thank you.
You're welcome.
Thanks, Eric. Really appreciate it, man.
Great to have you. That's a wonderful summary of the ICL.
Yeah.
You know, my thoughts about cervical deformity are that we're still in a relative infancy in understanding it relative to the thoracolumbar spine, and it's much more complicated because it pivots on that base a lot more. But you know, the other thing about the cluster analysis too is as much as we want to put things into these categories, there's lots of mishmash and variations of combinations, I think, of the above, you know?
Yeah, I couldn't agree more. And because it's involved in compensation so much, I think that's why you need to focus on the rigidity. You and I have been saying that for years, right? Look at the extension x-rays, really see what happens to those. And so I do think that's the critical piece of understanding how dynamic the cervical spine is and where it's fixed. And then just because you see a deformity doesn't mean you need to fix it. So it's the same as everywhere else. I think the other thing that we've found is that these patients are really frail. And so if we operate and do a huge operation to make every spine in the world straight, we are going to have a lot of people that are very unhappy with us. And so we got to be cautious and fix the problem that they came to us for, right?
Yeah, a lot of feeding tubes and a lot of death.
Exactly.
Yeah, right. Well, thanks again. I know you got a hard stop.
Yeah, I got to roll.
Any questions, guys? Okay.
Thank you
Thanks,
so much.
Good to see Eric.
Great talk.